Good evening, everyone. I'm Mohammed Jafar. I'm at Children's Hospital. I'm also on the board of trustees of the Prevention of Blindness Society of Metropolitan Washington, and I happen to chair the medical committee. It is my greatest pleasure to be with you tonight to talk about the children's eye health. And we are truly privileged to have Dr. Nancy Morrison from Northern Virginia, who is going to talk to us. Dr. Morrison had her medical degree in New York and then her residency in Louisville, Kentucky, then a fellowship in pediatric ophthalmology and strabismus at the Johns Hopkins University in Baltimore. Lucky enough for our area, Dr. Morrison moved to the Washington metropolitan area, practiced in Maryland for a number of years, and then in Northern Virginia. She is an expert in any topic in pediatric ophthalmology and strabismus. As you know, strabismus is misalignment of the eyes that happens mostly in children, but also in adults. And she also is an expert in the other diseases that children might have, be it uveitis, inflammation inside the eye, retinopathy of prematurity that very premature babies may have in their eyes, to treatment of anywhere between needing glasses, to children who have difficulty at school, to children who have systemic diseases like diabetes and hypertension and rheumatoid arthritis and so on. So we can ask Dr. Morrison any question and she will, I'm sure, give us the right answer. But most importantly, let's hear her first make a presentation, and the program allows us to have questions and answer at the end. So without further ado, Dr. Morrison, thank you for being with us, and please share your screen and we're all ears.
Great. Mohammed, thank you so much for such a kind introduction. And I want to also thank the members of the Prevention of Society, Blindness Society, for asking me to speak with you this evening. It's quite an honor. As Dr. Jafar said, I'm a pediatric ophthalmologist. I do practice in Northern Virginia with Northern Virginia Ophthalmology Associates. I thought I'd start off with the evening just talking a little bit about what we do as pediatric ophthalmologists, and then go on to how we help to integrate the care of children with the families, the schools, the teachers, and other healthcare providers. And lastly, then I'd like to touch on some sort of current topics in pediatric ophthalmology. Let me... I have no financial disclosures. I do also want to put a plug in for the Prevention of Blindness Society. They have some amazing programs that they run, really to help us find children who really are at need and provide access to glasses and intervention at a much reduced cost. So again, this is a broad topic. This is kids' eye health. I'll just do sort of a brief overview of what we do. If you have any questions at the end or anything specific you'd like to ask, please reach out to me. So why is vision so important? And when they look at our sensory system, vision is so important. It's how we receive most of our learning, and our cognition is through a vision, and 80 to 85% of what we take in comes through vision. We're fortunate with the onset of the new vision screening techniques that we are able to catch disease processes at a much earlier age and have a much more capability of doing intervention at a younger age, which also helps us with better outcomes. So as pediatric ophthalmologists, we are concerned with the development of the vision. As Dr. Jafar mentioned, amblyopia, which is poor visual development at an early age. We also concern ourselves with the way the eyes work together, depth perception, the eye alignment. We're concerned about eye health. And in particular, we're concerned with the eye in conjunction with systemic diseases. We do have to remember that kids are not adults, that they are still developing relatively rapidly, and they don't see like adults. So one of the things we do know with the way the visual system matures is that we develop on sort of maturation of the sensory part of the retina, the rods and the cones in particular. It allows us to have more clarity of the vision. It also allows us to help with our color vision. In addition to the development of the rods and the cones, we're also developing and improving the wiring between the eye and the brain to the part of the brain involved with vision. In addition to the development or the maturation of the retina itself and the nervous system, the eye itself is changing in size, both in length and in the curvature of the front of the eye. And these things are important for us to know when we assess children, that what we anticipate their eyes or their vision to do and change over time. So we wouldn't expect a 3 to 4-year-old to see 20/20 because of the way the visual system matures. So the aspects of what we look at when we check children out, we try and evaluate their far and near vision. We try and evaluate their color vision, their binocular, their vision to use together, and their depth perception. We look at also pupil function, the way the eyes move, the way the eyes change in focus from distance to near, and then we're also looking at the structure and the health of the eye. So eye charts are important to have different tools for us to look at in order to evaluate children, because not every child can see or tell us what they're seeing. So we do have charts to help us with children who have dyslexia, who reverse letters. We do also have picture charts to also help us. When it comes to depth perception, this is the brain, again, the brain's ability to judge where things are in space. And we use a 3D vision test. We also will do some other sensory tests with red-green glasses sometimes that you've seen. But depth perception is important in a day-to-day function because it allows us to judge where things are in space and gives us a better quality of vision, and it helps us to interact with the things that are around us. We also do evaluate color vision. Color vision is important, obviously, for when children are learning color in school. We do want to make the teachers and the parents aware if the child is color deficient. And about 8% of the male population actually has red-green color deficiency. We do evaluate the pupillary exam. That's important for many reasons. Not only when focusing, but also in certain disease processes. Then the eye movements are quite important, and they're controlled by different muscles, which change the position of the eyes. We also evaluate the way the eyes will change focus from distance to near. And we are often questioned or asked why a child may have a reading difficulty, and we will be evaluating the way their eyes change focus from distance to near. In addition to the way the eye's alignment change and the pupil size changes, we also are seeing if the eye is actually focusing the image. Then we check what we call refractive state of the eye. We're checking to see if a child might be farsighted, nearsighted. We have different techniques to do. Obviously, some children can't sit in front of this machine. Then we're looking at the eye health. We're looking at the front of the eye as well as looking at the structures at the inside of the eye. So common disorders that we are evaluating as pediatric ophthalmologists include amblyopia, which is poor development of vision. We're also checking or evaluating alignment or misalignment of the eye. We use the term strabismus. And then we're also evaluating refractive errors. But these are just some of the common things that we're seeing, certainly not the full gamut of things that we're evaluating. So amblyopia is basically a poor development of vision that occurs early in childhood or in infancy. We want to treat this at an earlier age because the treatment or the results are better. We do know there's a window of time. We do know the window of time is from about birth to around maybe 12 to 14, but it certainly is much more difficult to recover vision at a later age. What things can cause amblyopia? Well, we do know misalignment can, because a child may choose to see with one eye more than the other eye, and they will tend to suppress or shut off the vision in the eye that is not lined up. Other things that can cause is uneven prescriptions, things that also block the view or block the conduction of light into the eye. whether it be a cataract or potentially an eyelid that blocks the vision. What types of things do we do to treat amblyopia? Well, we use glasses. Sometimes the glasses alone will take care of the problem. Otherwise, we sometimes will use patching. Sometimes we'll use drops, and sometimes it may require surgery. The next thing that we do evaluate quite a bit is strabismus, or misalignment of the eyes. And that can come in many different flavors, from inward crossing to outward crossing, to eyes that give the suggestion of crossing, but in fact are straight. Again, with the misalignment of the eyes, there's multiple ways that we can go about for treatment. Sometimes glasses alone will take care of it. Sometimes we'll require patching. Sometimes we'll use drops, prisms. I don't know if you can see in this child, but sometimes we'll use prisms that adhere to the glasses, or they can be ground into the glasses. And then also sometimes it may require surgery. I did want to touch on refractive errors. We are screening, or a lot of the screenings are children who fail the screening, and that they will come in and say that they are nearsighted in one eye, farsighted in one eye, have astigmatism. But I wanted to kind of give you just sort of a general overview of what refractive errors are. So when we see something, we see the light that bounces off an image. That light needs to pass through the structures of the eye, and we want it to come to a point focus on the back wall of the eye. In an eye that is nearsighted, that image does not come and focus on the back wall of the eye, rather in front of the retina. A farsighted eye, the image will come and focus behind the retina. And then astigmatism, the image does not come and focus clearly because of an irregular curve to the front of the eye. And I often have so many parents come in and say that my child has an astigmatism. And it sounds like a disease process, but really it is just more an abnormal curvature to the eye. Any of these, what we call refractive errors, can be focused or change focused by the use of lenses in front of the eye. And I just been giving you sort of an idea of what glasses can do. So this would be glasses for nearsightedness, what they would see without the glasses around that, and then looking through the glasses and the clarity. And then astigmatism, having sort of irregular shapes or almost doubling to the images, and the glasses bringing those images into shape and to view. The other thing that we're evaluating quite a bit is actually learning disabilities or reading issues, looking to see if the eyes have any component to the children having difficulties. So one of the things that we'll be evaluating quite a bit is actually the ability to change focus from distance to near. And we often hear kids come in with the diagnosis of convergence insufficiency. I wanted to kind of delve into that a little bit, because convergence insufficiency is not all that common, and sometimes I feel like it's a wastebasket use of focusing problems. So what potentially can cause the ability or problems with changing focus from distance to near? And sometimes alone it can just be glasses. But we do see that concussions or trauma can also sometimes impact the way that the eye will change focus. I have seen quite a bit recently with antihistamines, changing ADH medications, even eye drops, like allergy drops, sometimes can impact the way the lens of the eye focuses. And the reason I wrote environmental, I've had some children over this past summer who were out in a big field, and they rubbed up against a weed, rubbed their eyes, and then the particularly milkweed caused the eyes to lose near focus. So I brought these pictures back up again of what's involved in the change of focus from distance to near. So the first thing that we want to look at is we're looking at, does the image of the light change focus? So we'll have a change in the lens itself. Then we want to look at the position of the eye. We want to make sure that the eyes go from a parallel alignment to a converging or inward turning alignment. Then we also want to see that the pupils change focus. So convergence insufficiency, we really have to evaluate, or a pediatric ophthalmologist really needs to evaluate the way the eyes change and the dynamic function of the eyes. So we do often get the question from families of, when do I need to have my child seen? Well, certainly if they have a misalignment of the eyes, if they're having headaches and the headaches are occurring frequently during the school hours, if they're having focusing issues, and also if they're failing the vision screening. So some of the newer topics in pediatric ophthalmology, we are talking a lot about the progression of nearsightedness. Nearsightedness has kind of skyrocketed in the world's population, and genetics alone are not accounting for the progression of nearsightedness. There have been lots of studies recently looking at the use of atropine drops for the treatment of myopia, as well as some other treatment options. So what is atropine? Atropine is a drop that we use in our office to dilate pupils. We are not using the strength that we would use in the office. We use a 1% in the office. But what we're using for the treatment of myopia is really a much less concentration. It's a 0.05%, a 0.025%, or a 0.01%. These drops are used nightly. There has been a significant drop in the progression of nearsightedness, not reversing course, but the progression of it getting worse. And why is slowing down nearsightedness or myopia so important? Well, we do know that higher nearsightedness or myopia is associated with many risk factors with the eye, particularly retinal detachments, a higher risk for glaucoma, and certainly higher risk for blindness. So there are some things in addition to offering these low-dose atropine drops. From the large epidemiologic studies that have been looked at, we are recommending that children get much more outdoor light, recommending 1 to 2 hours per day. We also are recommending a limit of the near focus with or the electronic time. There are also specialized type of contact lenses that are available on the market, as well as sometimes we'll be using bifocals. There, our organization, the American Association of Pediatric Ophthalmologists, as well as the American Academy of Pediatrics, have basically statements or review of all the literature and statements as to what's the appropriate amount of time by age for children to be on electronics. And then we have excellent reviews on our website for myopia treatment, as well as in addition other more in-detailed assessments or evaluations of amblyopia, as well as strabismus and other eye conditions. I also wanted to touch on some learning disabilities that we're often evaluating or being asked to evaluate, is whether or not the vision or the visual system is causing the learning problem. And we often are getting asked to evaluate children, particularly with dyslexia. So dyslexia, we know, is not an eye issue, nor is it a tracking, quote unquote, tracking issue. And that training the visual system is not going to treat the problem. Rather, dyslexia is a brain processing problem. It's basically a language processing issue. And we know this by studies by Dr. Sally Shaywitz, who's at Yale University. She's done some very eloquent studies looking at the functional MRIs of brains of people who do not have dyslexia and people who do have dyslexia. And people with dyslexia basically are not sending the signal from the visual system to the language centers so that they're not decoding what the symbols are showing. There are numerous, if you look at her website at the Yale University website, she's got some very excellent details about this. She also has books. There's a recent book out about dyslexia it's quite interesting and quite detailed. So our role as ophthalmologists in evaluating a child with learning disabilities is to make sure that the child doesn't have a visual issue that's causing blur or a misalignment or poor vision. So are glasses necessary, or is treatment necessary for misalignment or amblyopia? Then we also can help to coordinate with the educators to assess the need for other things, whether it be increased size of print, greater allotted time for work. Also, is a preferential seating necessary? Then we can also make suggestions or to the family or even to the teachers that there may be additional referrals to specialists for the child. Now, this is just very brief, but we just wanted to touch base on red eyes because I know that there's been a lot of that recently in my office in particular. So causes for red eyes certainly can be a multitude of things, but the sort of the big categories of things are going to be conjunctivitis related to viral infections, allergies, and bacterial conjunctivitis. So the big one that we want to be most concerned about is viral conjunctivitis because that can be very contagious and be passed around. So viral conjunctivitis, I kind of tell the family that you want to look at the company that it keeps. So if they have an upper respiratory cold, they have a sore throat, that the red eyes probably are related to a viral infection and that they need to be cautious about sharing hand towels, making sure they're doing hand washing, and wise to keep the child away from school. And we do recommend that they keep the child away from school so that it's not spread around the classroom. Allergic conjunctivitis is going to be more common with allergy type symptoms, whether it be itchy. The eyes tend to have a clear discharge. Usually we'll have some congestion. And a lot of times they'll tend to have sort of what we call allergic shiners, very dark circles under their eyes. Bacterial conjunctivitis will tend to have a more sort of mucousy discharge. It'll tend to be much more adherent and sticky. They may require antibiotics in order to recover that, but this is less likely to be contagious. The other thing I've been getting a lot of, and I think people will see quite a bit of, is bumps on the lids. We do have sort of different categories of these. We have styes that may be infections around the hair follicle near the lash line. These tend to be very painful, may require antibiotics, definitely warm compresses to help to clear it. And these typically are fairly self-limited and don't require too much intervention other than antibiotics. The other thing that we will sometimes get is the chalazion, and chalazion basically is a clogged gland within the lid. The gland clogs up, it continues to produce oil, and then it ruptures within the lid. And then that rupture, the body tries to wall off the foreign body material that's in the wrong position, and you get this hard knot. These typically are not painful. We do try and use conservative therapy to try and get them to go away. We warm compresses. Occasionally we'll use a anti-inflammatory medication, and rarely we'll have to drain these if they get quite large. So again, I wanted to do very, very brief overview about kids' eye health. I wanted to give a shout out to the Prevention of Blindness for their programs, the Bright Eyes, the Affordable Eyeglass Program, and the Glasses for Scholars. Thank you again for having me speak this evening. I'm certainly open for any questions that you might have.
Dr. Morrison, Nancy, thank you so very much for an unbelievable, nice review, very lucid. I learned, as I always learn listening to you. And it will be nice to open it for questions and answers, as you said. One thing that I didn't mention when I introduced you is how much of a volunteer you are in volunteering in the programs of the Prevention of Blindness Society in our community and also all over the country and in impoverished countries. So thank you for doing that, and I will just sit still and listen to questions and answers. Thanks again.
Thank you very much, Mohammed.
All right, thank you, Dr. Morrison. So we will open up time for Q&A now. So for anyone who has a question, could you please enter it either in the chat box or in the Q&A box? Either of those will be good. One quick question that we have already is, at what age should a child first see a pediatric ophthalmologist?
That's a good question. So I tell parents this is, if there's a family history of eye problems, it's better to see them younger. And we certainly are seeing infants that were premature that will be coming into the office. So we're seeing very young children. If there is no family history, I feel like the pediatricians are doing actually a good job of screening because of the new screening materials or techniques or the instruments that we have, that we're picking up things much faster. But certainly if the family has concerns, the earlier the better. And, you know, that I can't give you a specific age, but I think that it's better if they come in earlier. We can certainly rule things out and address issues if they are there. Mohammed, I don't know if you have anything you would like to add to that?
Not really. I mean, during your presentation, you said that, you know, one thing in pediatric ophthalmology is amblyopia, lazy eye. So as you said, the earlier we detect any issues, the better off we'll be. And I go with what you said, unless there is a family history or the child fails a vision screening test at the pediatrician. Pediatricians have really listened to us.
Yes.
And our senior colleagues really should take credit, because they spend a lot of time talking to pediatricians to let them know what are the red flags that they should look for. And pediatricians see the babies as of one day of life, and then on baby clinics, and they listen to the parents. And the other resource is the school nurses and teachers.
Yes.
So you have the parents, you have the school nurses, you have the grandparents. Somebody is going to detect something or suspect something, and if there is enough suspicion, we'll see them.
Yes.
But we don't need routine eye exams at the pediatrician's office, pediatric ophthalmologist's office.
Well said.
All right, next question. What happens when a child goes undiagnosed with amblyopia or strabismus? Can they actually lose their vision?
Well, they can end up with very, very poor vision. I do have some adult patients that I've seen that never were treated for amblyopia, and their good eye may be 20/20 and their bad eye may not see beyond 2400, the big E on the chart. So yes, they can have very poor vision. I don't think I've ever had anybody not see at all from an eye, but I've had some very, very poor vision.
And Sean, one thing to add, there are a lot of studies, especially coming from Australia, saying that if somebody has one good eye and one bad eye, these people are probably at 3 times higher risk of having injury to their eyes. And God forbid they have injury to their eyes, 3 out of 4 times the good eye is affected. So we don't want people to have a lazy eye and lose, if for nothing else, lose their spare eye. So it is extremely important to make sure these are detected and treated early.
Right, right.
And they still respond.
Right. And Mohammed, I totally agree with that. The other thing is getting protective eyewear on. I can't say enough about that. Too many times I've seen, a 14-year-old who never wanted to patch their eye and has very poor vision, refuses to wear glasses, and a freak accident happens and they lose their good eye. And now they're stuck with an eye that they can't drive with. And it really impairs what they can do for the rest of their life.
No doubt about that. Accidents happen in a blink of an eye.
Absolutely.
All right, we have another question. As a childcare professional, like a teacher, what are the top things folks can focus on or be on the lookout for when it comes to their students or their child's eyes?
So I would look for so struggling in the classroom. I think particularly a teacher who sees 20 or 25 kids, they can kind of tease out the child that seems to be having problems seeing. Also, certainly if there's a misalignment of the eyes, that would be sort of definitely a red flag for me. I think if you see sort of unusual sort of head postures, if they're really moving their eye to one side, or they're squeezing or blinking their eyes a lot, sometimes those can be indications that they're having problems with their vision. Delay in reading, that can be another thing. Delay in, and it may not necessarily be vision, but we want to make sure it's not vision.
Okay. Here's an interesting question for you. Can a child still pass a vision screening at the pediatrician but have eye issues?
Yes. Yes. So the photo screeners are not a perfect, it's a screening mechanism. I tell the parents it's a screening mechanism, and that they may be a little bit off straight on alignment. There may be something else going on, so it's a screening mechanism. And the other thing I sometimes will have is pediatricians checking the vision of a child in a hallway using one hand to cover an eye, and they're kind of peeking through the fingers, and they're really trying to test one eye, but they're testing both eyes because they're not really closing an eye. So yes, they can pass a vision screening, but really be failing it because they're not being tested properly.
Thank you. All right, folks.
If in doubt, repeat the test.
Yes.
Beyond family history and premature birth, are there any other risk factors for amblyopia?
An injury to an eye. Let's say there's a deformity in the eye, the way the eye, either the front dome of the eye forms, or there's a cataract, or there may be a deformity in the retina. That can also be a setup for amblyopia. It's basically a poor visual input from the eye being sent back into the brain, so that the brain isn't learning to see. So if you have any of those things, that could be potentially a cause for the vision not to be developing properly.
Sorry, Sean, I'm really not sure if we got your question correctly or not. I mean, some children are just born with the eyes different. So if a child is born with a normal eye and the other eye is nearsighted, the nearsighted eye is going to be neglected and develop amblyopia. One eye is normal, the other eye is farsighted, or drooping of the lid, as Dr. Morrison has mentioned, or if the child is born with a cataract, be it one eye or both eyes. So yeah, there are a lot of conditions that the child may be born with without a family history or anything like this. I mean, amblyopia is a little bit more common in families than not, but it doesn't, I mean, it can happen in otherwise normal families with no eye diseases. And this is why it is very important to have the vision screenings at the pediatrician's office. And again, even earlier than 1 year of age, if there is any suspicion or a family history, as Dr. Morrison has already covered very nicely.
All right, somebody's asking, what's the difference between amblyopia and strabismus? Can you help explain further?
Sure. Well, strabismus can be a cause for amblyopia. Strabismus is a misalignment of the eye, so the eye's alignment can be turned in, or they can be drifting out, or one higher than the other. So strabismus can cause amblyopia because the eye that's not lined up, the brain in a child, instead of seeing two images, will shut an image off. They'll not use that eye that's not lined up. So we try to address the poor vision, let's say patching, and that may in turn help with the control of the alignment. It may not completely. We may need to use other things like glasses, or maybe prisms or maybe surgery, but misalignment is strabismus, it's the eyes are not lined up properly.
And there is also a little bit of a disconnect between what we ophthalmologists call a lazy eye and what lay people call a lazy eye. We ophthalmologists talk about a lazy eye as a vision that cannot be corrected with glasses or any other method. But lay people, many a time, especially in a few years back, may be used to say that the eyes are not straight or one eyelid is droopy.
Right, right.
And that's,
I tried to tell parents that's a big catch-all phrase, and it's unfortunately isn't helpful sometimes describing what's going on.
and back to why the screening is important, because you know the eyes to the outside may look very, very normal, but again, if one eye is nearsighted and one eye is not, you can't really see it by looking at the child's face, and the child doesn't know about it because the child has both eyes open and they see very well with both eyes open. It's only when one eye is covered to be examined or the other. And I shouldn't cover my hand, my eye with a hand, covered real well. We all have cell phones now, okay, but really covered. And children are very smart. They can peek, you know, very much. So, you know, put a patch on the eye, a tape or something like this is the best way to check each eye separately. Very good questions. Keep it coming, Sean.
You got any more?
We do. My apologies. I was muted.
Oh, okay.
Thinking about older children now, these older children, they need glasses. Have any of your patients experienced better grades after getting glasses?
Of course.
Oh, yes. Yeah. And I certainly have older children who don't want to be seen in glasses, and they'll get their glasses and stick them in their backpack and not wear them. And then they get the note home from school that they didn't catch what was on the board, or they didn't do the homework that was written on the board. So, yes, you do find older children for various reasons, whether they're farsighted, nearsighted, or astigmatism. Yes.
All right, folks, we still have time for another question or two. Please feel free to enter into the chat box or into the Q&A. We can take either or. And this is being recorded, so don't worry if you miss anything. You feel free to just stay tuned. By the next day or so, we will be sharing the recording with everyone. And also, we do have a post-event survey. I put it in the chat box, and we will share it with you too. We hope you all can give us some feedback because it helps us out with making sure that we're providing the best service possible to the community. Okay, we have another question here. For the kids who don't want to wear glasses or just flat out refuse to wear them, at what age would you think of letting them have contacts?
Oh, that's a good question. So I evaluate the family, and I evaluate the child. Certainly I've had some children who are more mature than others, and I've had some older children that I don't think are good candidates for contacts. I really have to take into account the involvement of the parents. I mean, for instance, I had a little girl who was a dancer, and she had very thick glasses and couldn't see the end of the stage without her glasses, and she was in 3rd grade doing dance competitions, and we put her in contacts, but the mother was really, really involved with it. But that was just a special circumstance. So I take it, you know, each case by each case.
Thank you. We had another question come in, and they're thinking about, you know, we're doing more and more time usage on the screens, whether that be in school or outside of school. Are there studies or is there data that's showing any sort of trends of increases in vision problems among kids with this increase in technology usage?
Mohammed, you want to? I feel like that's a whole talk amongst itself.
Well, that's as Nancy just said, it's a very interesting topic, and a lot has been written on it, especially during COVID. I had to give a lecture about this, so I reviewed the literature. And believe it or not, yes, children who stayed home during COVID and were spending more time on electronics and so on did develop a little bit more nearsightedness. The trend went up. But when the data was really looked into, it turned out that kids who had increased nearsightedness did have increase in nearsightedness because they spent much more time indoors than outdoors. So my conviction right now, having reviewed so many of those papers, is that it is not the near vision and spending time on electronics that hurts the eye. Maybe they hurt the brain, but not the eye. I think spending time outdoors is really the panacea to delay the onset of nearsightedness and also to slow down the progression of nearsightedness. I'm very, very strong believer on that. And I'm waiting for the studies which have started already, is to have children spend time on electronics outdoors versus children who spend time outdoors playing, running, doing sports, just chatting, just spending time outdoors. Doesn't matter if it's sunny, cloudy, rainy, snowy. It is the type of outdoors light that apparently is extremely helpful in delaying the progression of nearsightedness. Nancy, sorry, we did not rehearse that.
No. That's exactly.
Yeah,
that's exactly. I mean,
my
the
very
literature I've
strong,
looked at as well.
yeah.
I always make the analogy to the parents that if you look at the intensity of light inside and the spectrum of light, because light is broken down into its color, that it's so much less intense inside than outside, that you're getting a much fuller spectrum of light outside and you're getting a much more intense light. And when I tell parents, your children need to be outside, I don't say go lay out in the sun with the mirror and the betadine or whatever, but to go outside and play, because it really does help. The other thing I make the point to the parents, though, is if your child's on electronics all the time, the other thing that they're missing is the development, I think, of big motor skills, imagination, interacting with other people. And I think they're losing those skills if they don't interact with other kids and they don't get off their electronics.
Yeah. Very, very true. They don't know how to communicate with each other. It is really important. Outdoors is really important, and it's you change your way of life. And I tell the parents, it's good for the brain, it's good for the bones, it's good for the eyes. Just do it, and you feel good about yourself too. So.
Yeah, I did have some strange things happen during COVID with kids that I have not ever seen before. That kids who had basically normal eyes and normal eye alignment and normal vision coming in with their eyes crossing.
Yeah.
And having to go into reading glasses. I've never had that before. I mean, I had a good probably 20 kids that happened to during COVID because they were on their computer so much.
Yeah.
It was just an odd thing that I had never seen before.
Wow.
COVID changed our lives.
Yes.
We've seen things done differently, and we've seen different presentations of different diseases, no doubt about that.
Yeah.
But again, outdoors, I always say an hour a day. You said 1 to 2 hours. I mean, the more the merrier. And I've seen families who have been on the outdoors, and they're all really doing very well.
Yes. Yes.
Okay. All right, and this will be the last question. This is for school age kids. So who is catching these vision issues more often, the teachers or the parents?
Or
do you know?
whom do you love more, your mom or dad? I love them both.
Honestly, I think the pediatricians are doing a great job. I really do. I think that they are I think the new awareness and the screening techniques that we have, I think it's actually been a big help. I think it's just been a much more aware of what's out there and what's available and what can be done.
And it's also a change in behavior. If the family notices that the child's getting closer and closer to their books, closer and closer to the TV, to their computer and so on, that's a start. And, school children are very smart. I mean, they complain themselves. So
Yes.
Somebody is going to catch it. I'm not very concerned about school children, except in the pockets of our society that are disadvantaged. But in general, somebody is going to catch it in school children, either the child, the family, the teachers, the school nurse, the Lions Club, the prevention of blindness, somebody's going to catch it. The difficulty is in the younger children, where we really want to detect amblyopalagia eye early and treat it early. This is the more difficult one.
All right. Well, Dr. Morrison, thank you so much for having us for joining us today. We really
Thank
appreciate you
you.
coming on. This is a
Pleasure to meet
great
you,
presentation.
Sean. And Karen, pleasure. And thank you, Mohammed, very much.